Very much for the invitation, Jan. It's a great honor to be here. So it's already a great discussion we had today. I will try to keep it as short as I can because we had a really long and very interesting day. So I will try to be as fast as I can. Well, I like the philosophical touch that you gave us, so I will try to bring us to the past for 1 or 2 slides, and then I'm going to try to find out if it's good what we're doing with the younger patients or not. Maybe we can find an answer, maybe not, we will see. But indeed, it is true that compared with metastatic tumor disease, the symptomatic aortic valve stenosis is associated with dramatically increased mortality. This is true, so it is a big issue. If we want to understand how we approach the patients today, we need first to look back what we have done. We all know how it all began, 2002. You see a picture of the first-in-man patient in Germany, and Raimund Erbel. And this is like, I had the honor of being part of his team. And I remember how crazy the time was when everybody thought, what is this new procedure, like pressing the calcification in the wall, and it will not have any future at all. And the initial approach was through the septum, transeptal, and externalization of the wire through the aortic valve, another totally different world, definitely. But the years go by, and emerging challenges is the topic, because I think we do need to talk about what can go wrong, what are the big 3 or 4 that need to be addressed before we talk about younger patients. These are problems that we do have that are not resolved yet, and we just have to take a look at that before going further towards the younger population. So we do have the paravalvular leak we talked about before. It's a big discussion when it is relevant and when not. Definitely, I do believe that at least moderate paravalvular leak plays a role. Does mild paravalvular leak become relevant or not? It's a good question. The hemodynamical importance is maybe key to see, do I have an approximation between the diastolic pressures or not? It's definitely something we do need to avoid. We do have the stroke or subclinical microembolic events, which have not been that critical after all these years. Initially, we had fear of that. Now it is not that critical, and we have certainly the access site complications. We do use multimodality imaging. We do try to improve ourselves the whole time, and I will talk about pacemaker and rates and association with outcome also later on. So because it's late in the afternoon, I would also like to show you a case, and we'll be glad to ask a question, how would you treat these patients? So we have like a 68-year-old patient, which is for Europe still under 70 years old. For the United States, it's something that it's doable for TAVI, but we are not crossing this border easily. And he is presented with NSTEMI and with the low flow, low grade aortic stenosis, and had the coronary angiography afterwards, which revealed this left main. So we have a patient with a severe aortic stenosis, symptomatic, is young for us definitely, and he has this left main. So the question, I think, I don't know how Shakespeare asked the question, was it like to stent or not to stent? I think that's what he wrote in Hamlet, and I don't know if the question can be answered here. It's like many roads lead to Rome, so this is definitely the case. There is no right answer to that question. It's definitely the case. So what do you do with such a patient? Like surgical bypass with surgical aortic valve replacement? Do we do like the left main and TAVI in a second session? What happens if we have ventricular fibrillation and during left main procedure? Do we do impeller PCI? It's doable if the aortic valve area has a certain capacity. Do we do both simultaneously like a surgeon would do it? This is also a question. So like I said before, there's nothing right or wrong in this case. We chose the last option. We proceeded with TAVI as usual. We placed the wire to the left ventricle. we practically had everything set up, and the valve crimped and needed like half an hour in order to proceed with the PCI, because it cannot be crimped for a long time on the table, and then proceeded with an 8 French guiding catheter with the left main PCI. Why 8 French? So that we can perform a simultaneous stent implantation. So we froze the TAVI procedure, went further to the PCI, and worked with 8 French. Doing that, we just did some predilation in order to have some space. We went to the circumflex artery, and you see here, after predilation, we had on the right side simultaneously both stents placed. We implanted the circumflex stent, and then in an optimized nano-crush technique, pulled the balloon back, implanted the left main LAD stent. So we had immediately a new bifurcation without rewiring and pot and final kissing, definitely. But you have, at the end of the day, one step less, and you can quickly rewire and do the pot and the final kissing easily. So the result was fine, but we did see afterwards that the LAD had a dissection. We used another stent. The overlap was post-dilated, and the job was done. So you have practically, on the end of the day, the left main before and after this intervention. And so we have a safety. We proceeded with TAVI as usual. We used the sapien valve in this case, and you will not find something spectacular in this part of the intervention. So the question is, what can we do with such patients? They get younger, they have more than one issue. What is right, what is wrong? Do we really know that or not? So TAVI today versus surgical aortic valve replacement is a big issue. Where do we stand when we look at younger patients? What's the current evidence regarding that? And what are the guideline recommendations? So I will go through some slides. So I would like to show you this asymptomatic aortic valve stenosis, the recovery data of our surgeon colleagues. I think it was a very interesting study because it showed that asymptomatic patients, they were like 60, 65-year-old, have an immediately benefit after surgery compared to conservative treatment, which is like promising and understandable. We tried to do the same. You see mean age 64. This is really young, but there's an operation, like conventional operation from the surgery colleagues. And we tried to copy that and see what happens to TAVR. We all know these two studies, evolved and early TAVR. We have the early TAVR with the balloon expandable bioprosthesis, and evolved with the self-expanding bioprosthesis. So TAVR versus conservative treatment. We saw definitely in early TAVR that we had the combined primary endpoint we had a non-inferiority to place it like elegantly, and we had a significantly higher incidence for the conservative treatment. But it's a combination of many endpoints. And the EVOLVE trial was simply a non-inferiority case. We will not have to go through that. The big issue is here, so I want to place a comment. We had like an MRI fibrosis-driven trial. The question is, where is it early enough? These patients were all 70, 71. The patients of the surgical trial were like 64 mean. So if you have MRI fibrosis and you have an evidence of MRI fibrosis, does the trial test truly early intervention, or is it already too late? Do we have structural disease with myocardial fibrosis? So maybe it's not that early after all. That's what I'm trying to make, the point I'm trying to make. So we try to adjust the guidelines. We can see the asymptomatic patients, the younger patients, as a patient that we can treat if it's easy and if it's doable, and if we have a really high gradient. Definitely we reacted to that. And there's much more to come. The colleagues in the United States are a little more aggressive. We know that in general, so they treat patients under 65-year-old. We are a little more soft regarding that. 70 years is our border. We have adjusted a little bit, so this is a good thing for our patients. So does that mean we can treat everybody now? Definitely not. we know that we have to look at partner 3 and evaluate low-risk trials. The promising results we had in the beginning, if we look to partner 3, we had like 1-year results that were fantastic. We had increased death, stroke, rehospitalization, which was significant. We had new onset fibrillation was significantly lower compared to aortic valve replacement, and we had definitely was the first trial to demonstrate that there was no significant difference regarding pacemaker implantation. It's a very big issue after TAVR, the first trial proving that it can be done without more pacemaker implants compared to surgery. On the other hand, we have the long-term or a mid-term follow-up of partner 3, proving the non-inferiority, still having a statement, not that, let's say, impressive as the 1-year results, but still is a non-inferiority aspect regarding the combined endpoint. And we do have, in terms of stroke and hospitalization, still a non-inferiority proof. What is really important here to say that hemodynamics were not worse than aortic valve replacement. So the myth that TAVR is combined with worse hemodynamics due to the fact that the nature of the procedure can affect the gradient. In the AVA, that was not the case. We were similar compared to surgery, which is a promising result. And of course, we didn't have any bioprosthetic valve failure or significantly more than surgery, which is also very, very promising. If we look at the self-expanding low-risk trial, we had a clear non-inferiority over the first 12 months. It was pretty clear, and we had particularly impressive were the significantly lower rates after 30 days in the TAVR group regarding stroke, bleeding, acute kidney injury, and new onset atrial fibrillation compared to surgery. Nevertheless, we have to be honest, the surgeon colleagues will be unsatisfied if we don't say that. Though we really high, certainly not, but higher rates of paravalvular leak and permanent pacemaker implantation. So midterm and long-term perspective, it's a non-inferiority, but you do see that the lines cross. It has to be observed where the journey goes, the lines cross. So you have to see if it remains like that. The blue line is going up, the red line is going down, which is surgery regarding Evolut low-risk trial. And you do see here indeed an issue regarding reintervention due to aortic regurgitation, worse in the TAVR group compared to surgery. Non-inferiority data also confirmed, very interesting, TAVR versus surgery for bicuspid cohort. We do have to consider surgery for bicuspid valves. It is really a small group, but it's a big issue. On the right, you see that surgery does have something to say. Still, we do not have to take everything so absolute. And I do see that the great presentation before, we are going too quick. It was a very good point. Maybe we should have some second thoughts regarding that. And I'm almost done. We have the Notion trial also having findings that can be discussed. I mean, I don't want to be so direct regarding that. We have a lower rate of bioprosthetic valve degeneration in the TAVR group. Okay, it's true. On the other hand, we do have surgical valves like the Mosaic and the mitral flow, which are old, not that last gen. So we have to be fair in that. Or if that's the case, we have to observe it in the future. Meta-analysis confirmed non-inferiority, definitely, and 2 or 3 slides regarding mild PVL. We discussed about that before. I'm certainly a fan of not leaving at least moderate PVL with hemodynamical significance regarding mild PVL. We can discuss about that. The data showed in Ocean trial that indeed also mild PVL can become a predictor for a bad outcome. And additionally, let's say the pacemaker implantation after TAVR is a big issue. We have data showing that new pacemaker after TAVR influenced the outcome, and indeed also we have a worsening of the left ventricular ejection fraction. So we have to avoid pacemaker and PVL after TAVR. This is the case. What favors for TAVI is pretty easy to understand. I think we all go along with that. 70 years old is the new border, and the other arguments are pretty clear. We have to consider the life expectancy, to my opinion. This is something that has to be discussed. We have a young patient but has another life expectancy due to comorbidities is a big issue that has to be addressed. And of course, we have to anticipate repeat procedure options and risks when selecting modality and prosthesis at index procedure, because we have to consider leaflet overhang, we have to consider coronary ostia and features that have been addressed before from my colleagues. I will not speak about that. This is the issue of the future. We have to deal about it with that and see how we can find solutions, industrial solutions, but also have to be creative. Danny had an excellent case regarding that. So it has to be continued. We don't have the answers. We have many, many questions. And I will leave you, unfortunately, with many questions, which is indeed maybe the energy of finding solutions. And I will allow me to show you the slide, final slide that I always show regarding football and World Cup. I have a slide that suits us cardiologists perfect. It's a football slide. I always show that. Success in football comes from a controlled attacking approach. That is a very, very good sentence. I always show that because this is, I think, the way we have to go. And I thank you very much for your attention.
How do you call that attack? It's gegenpressen. It's like a Jürgen Klopp's kind of attacking.
Exactly.
So it's good, amazing talk as always. So thank you. I guess so. We are the known knowns. It's the age of the patient, ARIC. So, but we have different definitions. So in the States, it's younger patients less than 65. In Europe or in Germany, it's 70. In Greece, it's 75 because of other factors as well. So it's always, it's so interesting. How do you plan the lifetime management? And maybe we can have also the comment from Dr. Dardas, who is online. How do you approach this patient? Because when you talk about a 70-year-old male who has aortic stenosis, so he doesn't have no matter what he does in terms of therapeutic approach, so he doesn't have that same life expectancy as the one who doesn't have aortic stenosis. So it's 9 years instead of 14. So you have to communicate that to the patient. So we shouldn't. Maybe, of course, we have surgeons as well. We have Dr. Perreas, Dr. Stavridis, Dr. Avgerinos, and maybe Dr. Pittis as well online. So you have to communicate this information to the patient, and he has to be part of the decision. It's all about him, right?
Yes, but as I have said before, the patient always wants one thing, okay? The patient doesn't want surgery. And this doesn't have to make us do things that we don't really believe in, like a patient who is 69 years old with severe aortic stenosis and distal left main bifurcation should have a very, very good reason not to go to surgery. I don't know what was the reason there. I can tell you one thing. We've done pretty many patients with left main and aortic stenosis, not 69 years old, but we've done. And one of my experiences that I will always start with the valve. Whenever you start with the left main, and I'm talking about tight left main, in a patient with severe aortic stenosis, you just cross with the wire and the patient collapses. So just forget about the left main, do the TAVR, and then correct the left main. In spite of the fact that always we're doing the opposite, in the left main issue, always I'm doing first the valve, if I have to, right? And then the left main.
This is fantastic. Really, this is a great debate, because I would like to have the question that I would have to raise is that First of all, I believe you have, there's no right or wrong. We don't have really any data regarding that. But if you have this left main, our consideration was the patient was going direction cardiogenic shock. So we have other issues. He has an ejection fraction of 32%. And we had the left main discussion because if you have CPR with this aortic stenosis, you have an issue. So you cannot just do the left main without addressing the valve. And addressing the valve with this left main, like, it's practically nothing left. It's really subtotal. It's also an issue regarding having to reconstruct this left main if you want to go, of course, for TAVI. But if you consider surgery, I give you that point, you have these issues not at all. You have another concept. But the way you go was a big discussion also in our hospital, and the issue you raised was also on the table, certainly.
Yeah, but if the reason not to send him to surgery is the fact that he had 35% ejection fraction, this is not a reason.
He was almost cardiogenic shock, and you have the discussion where the surgeon says he has to cool down, that's not the point, and we say we have to do it immediately, and you have this discussion on the table.
I understand. I do not argue with a certain point because I was not there, but in general, a patient who has severe aortic stenosis and tight left main, the EF of 35 is not a reason not to do anything because the 35 EF is due to the aortic stenosis and left main.
Yes.
So if he goes to surgery after putting an intra-aortic balloon or impeller, whatever, as a support, goes to surgery, he goes out a completely healthy patient.
Yeah.
So this is not a reason not to surgery. And come on, guys, I'm not an advocate of surgeons, but I think that surgery is not a curse, and patients should go to surgery. And a patient like this, I was not there, and I believe that your guidance was right, etc. We're just saying as a comment.
I agree. We have to leave it there because we're left behind. We have a. I guess so. Thank you so much.
Okay, thanks. Thank you so much.
So we have two